Of tonight's presentation on our YouTube channel within a few days. We are so pleased tonight to have Dr. Melissa Cortez as our speaker at our education meeting. Dr. Cortez is an assistant professor within the Department of Neurology at University of Utah Healthcare. She is also the director and founder of the Autonomic Physiology Lab. She is board certified in neurology and clinical neurophysiology. She completed her neurology residency at the University of Utah School of Medicine, and before returning to University of Utah Healthcare in 2014, Dr. Cortez served as a fellow at the Mayo School of Medical Education, where she received specialized training in clinical neurophysiology and the management of multiple sclerosis. Please welcome Dr. Cortez.
Thank you. I'm a little shorter. Good evening, and thank you for coming this evening, and thank you to those who are joining us virtually today and future streaming. Today I was asked to talk about what is, I think, a frequent interface between experiences of patients with chronic fatigue syndrome, classically defined, but also on that border, the border zones of that, and disorders that we're learning more and more about that are both neurologic as well as multisystemic. And we'll talk a lot about the overlaps of the different domains of nervous control of our other organs that can impact some of the symptoms experienced. So we'll talk all evening about a term, orthostatic intolerance, and I'll define that very carefully, and I'll show you ways in which we might define it in the laboratory to study it and understand it better. As in that introduction, I am a neurologist, so I'm trained to look for neurologic conditions, and most of our laboratory testing is focused and aimed at that. But certainly, there are many things we'll talk about tonight that are perhaps outside of the realm of classic neurology. So no disclosures relevant to this evening. As I mentioned, I'll begin with definitions, try to introduce you a little bit to some of the anatomy, and you'll find immediately that it's complex, and all about a set of balancing systems rather than a true lesion or hyperfunction of one domain. And to really send things home, I'll introduce you to some case patients to illustrate not just how symptoms manifest, but how one might approach diagnosis and how to treat symptoms in the category of orthostatic intolerance. So beginning with a couple definitions. So a term that I haven't yet used is my area of specialty is called autonomic neurology. It's our automatic portion of our nervous system that is controlled in multiple domains. So it's not just the brain, it's not just the spinal cord or the peripheral nerves, it's actually everywhere, and it's a part of our nervous system that helps coordinate our balance in our organ systems. And there's a term called homeostasis, which is the true balance of all organ systems working together to adapt to the environment in a survival beneficial way. And the autonomic nervous system is what allows us to maintain homeostasis in response to our environments, in response to stressors, in response to survival challenges and illnesses. And it coordinates all of our organs. And so you'll see in this little illustration, there are two domains, and I'll introduce these terms in a moment, but sympathetic and parasympathetic. And they're organized in different ways, but they all are targeting the same organs from different directions. Basically, one side says on, the other side says off, or simmer down now, amp it up. And in addition to this, our autonomic nervous system helps coordinate different elements of our metabolism. So how our kidneys handle salt and control our blood pressure, how our blood sugar is controlled, our pH. It has influences into all of these parts of our metabolic function as well. So again, this term, sympathetic, is a fancy way of talking about our adrenaline system or our fight or flight again, evolutionary adaptive element of our nervous responses to the environment. So it's what increases our heart rate, increases our blood pressure, lets us get away from the bear that's going to eat us. If hyperactive, you can see easily how that might be not beneficial. If underactive, also not beneficial. The opposite part of that balance is the rest and digest part of our nervous system, or this term parasympathetic. And this is the side that allows us to activate our gut, our bladder, the things that we do when we're hanging out and sitting around after running away from the bear and being thankful we survived. We then need to digest our food so that we can wake up tomorrow and do well. This is controlled by another important element that I'll talk about, vagus nerve, and some of you may have heard of that. That is the dominant nerve of this part of our nervous system, and it controls or feeds into largely our heart rate and our respiratory function, but also into our gut, our bladder again. And again, it's that rest and digest category. So sympathetic, alert, parasympathetic, rest. It gets more complicated than that. There's a lot of other structures in the brain and our brain stem. Our brain stem's what helps integrate everything that comes down from our brain that we think about, and how we integrate what we think to our reflexive actions that our body may do even if we didn't think about it. And that's where it gets integrated. And the autonomic nervous system actually has a master controller within this territory of our brain stem. So as you might notice just from quick, without even remembering all those terms, I just described all domains of the nervous system, all interacting with this element of how we maintain function. And how do these parts of our nervous system manifest when they're not working well? And the answer is almost any symptom. Because of all of those different organs that we pointed out on the previous picture, there are symptoms that can manifest from almost every organ group if the autonomic nervous system is imbalanced. And these can happen normally in response to the environment. If we're stressed, if we're exercising, it's a normal response or reflex to reply to an exercise stress with certain responses to our blood pressure and heart rate. But that can either be not functional enough in response to exercise, or it can be excessively functional. And we'll talk about some examples of both. So how do we measure all this complexity and these symptoms that could be very diffuse throughout a person's body in a systematic way? And this is where I came in as a neurophysiology specialist. So we just this last January opened a laboratory termed the Autonomic Physiology Laboratory. We're doing our best here to systematically study some of the reflexes that happen controlled by the nervous system with the target at diagnosing neurologic entities. And neurologic disease can manifest with autonomic disorders ranging from neuropathies to neurodegenerative disease, such as Parkinson's disease. And very many different types of conditions in between that spectrum within just the world of neurology. You'll notice on this little guy here that there's symptoms of delayed gastric emptying in the stomach, urinary frequency hesitancy incontinence in the bladder, sexual dysfunction also in a urologist's territory. We work with many different specialists because of the target organs that can be affected sometimes are outside of the realm of what a neurologist is typically seeing. So in our laboratory, we have a standard battery of tests, again, to get at sort of the most sensitive tests for neurologic disease of the autonomic nervous system. And we begin with testing sweat. Sweat functions in response to heating or stress and can be actually evoked through a little bit of electrical stimulation like a TENS unit. And we can actually capture evoked sweat in these little capsules here, and these lines show the volume that our machine measures through evaporation. We can also measure, I mentioned that term vagal nerve, the parasympathetic side of the nervous system. It has a lot of effect at modulating heart rate in response to some reflexes. And so we can measure those through deep breathing and a Valsalva maneuver, two things that we can standardize and reproduce within one individual and follow symptoms of impairment. We use these two different tests to test the sympathetic part of the nervous system, predominantly blood pressure changes in this case. And that, again, we use a Valsalva maneuver and a tilt table test. And I'll show you several examples of how tilt table testing can be helpful. As I mentioned, I work with a lot of other specialists in the domains of where these symptoms impact function the most. We work very closely with cardiologists. The tilt table test protocol we do for neurologic diseases is actually a shorter version of what cardiologists will use in their environment, which has a higher yield for testing certain cardiogenic or heart-caused problems of fainting. So a severe arrhythmia is better diagnosed in a cardiology laboratory than ours because of the way they set up their protocol. We also work with GI doctors to try to look for laboratory testing of gut motility dysfunction. And similarly, you can do the same with urology doctors to test motility of the bladder. Sleep is almost always universally disrupted in autonomic disorders. It's much more difficult for me to tell you exactly why in simple terminology, but it's so common. We're working in nearly everybody. We talk about sleep. Sleep studies are very valuable for helping get additional objective answers about what's going wrong with their nervous system. And then endocrine and rheumatology, again, an overlap of some of the conditions we'll look for that can cause autonomic symptoms. So let's transition to talking about 3 case examples of this domain and the symptoms and how we approach them. So fainting, or is also commonly known as passing out, lightheadedness, syncope, near syncope, many terminology used to describe this term. But another term that's less frequently understood is that of orthostatic intolerance. Partly that's because it's sort of vague, but if you think about exactly the words, orthostatic is to stand or to maintain upright posture and to not tolerate it. And so symptoms that worsen upon standing and standing upright for a prolonged period of time, and then get better when lying down or sticking somebody's feet up. You can also define orthostatic intolerance physiologically or through those laboratory tests I mentioned. And so you can see postural tachycardia or tachycardia, increase in heart rate that goes up when standing, postural upright, and blood pressure instability, which can occur either with an overt drop in blood pressure, sometimes accompanied by fainting, or just oscillations or instability of blood pressure that can actually be very difficult to pin down in just routine vital sign testing. And then there are delayed variants of both that can occur after being upright for a long period of time. And then we mentioned the term of syncope. The symptoms of orthostatic intolerance are diffuse, as I mentioned, some of those other things, but can be actually localized to certain phenomenon that we know happen when somebody's standing and feeling lightheaded. So lightheadedness, difficulty concentrating, headaches, and blurry vision is thought to be related to, with that unstable blood pressure, increase in heart rate, not enough blood to the brain, or cerebral underperfusion. There's also palpitations, chest pain, tremulousness that occur, and that's thought to be related to activation of that adrenaline side or the sympathetic side of the nervous system that gets overactivated in response to that instability of the blood pressure, and maybe as a reflex response to the brain not getting enough blood supply on a continuous basis. This underperfusion is not enough to cause a stroke or a permanent deficit. It goes away as soon as they lie down. And again, going back to the definition of orthostatic intolerance. And then there are non-specific symptoms we don't have a good mechanism for. Fatigue specifically, generalized sense of weakness or weakness that can occur in one location, and nausea and stomach pain that also accompany the above symptoms. So beginning with a young woman who had been previously diagnosed with fibromyalgia by a rheumatologist, was receiving treatment for that, and that's been a few years ago. But now she's coming in with new symptoms, and she wants me to figure out whether she has a dysautonomia, which is a term for autonomic dysfunction that can occur with all these symptoms we've been talking about when autonomic dysfunction is present. She describes that in the last 8 years, she went from just having fibromyalgia to becoming increasingly fatigued with any type of exercise or being upright. Things that she used to be able to do well, suddenly was not being able to do well. But it's kind of crept up on her day by day. It was worse and worse. And most notably, she would get much worse and a flare of fatigue, flare of pain if she did try to exercise. She called that payback fatigue, and she was definitely certain that all the doctors that had told her to try to exercise to get better were actually making her worse when she attempted to do this. It was a definite part of her symptoms. And then most recently, she started noticing some skin color changes that would occur every once in a while. When she was standing for long periods of time, her feet would turn purple. Or if she got out of the shower, she turned bright orange. And this was a new symptom she was noticing out of the blue, but was sort of in her mind connecting to these previous symptoms of fatigue. When I asked her more, she also had the sleep dysfunction. She had severe insomnia, couldn't get to sleep, couldn't stay asleep. Severe frequent headaches. Her migraines had recently gone to daily. And she felt like her memory wasn't as sharp anymore. In addition, she had a history of some low back pain, some anxiety, some irritable bowel syndromes. And I just described almost everything on that list in each of those domains as we started to explore more thoroughly. When she had her vital signs tested in her doctor's office, she had normal, healthy blood pressure when she was lying down, a slightly high heart rate, but normal range. When she'd sit up, it dropped a little bit, but not enough for anybody to be worried. And when she'd stand for even 5 minutes at a time, it dropped, a smidge more, but not so much anybody was worried. But she felt horrible standing here. So 2 terms that I'll define here now for you. One, orthostatic hypotension. So again, this with postural change, but now the blood pressure is dropping. And so we look for over a 20 drop in the top number, systolic, or the lower number 10 drop, diastolic. And you'll see here, she gets a drop of only 10 with her top number and actually increased her lower number. So she doesn't qualify as having orthostatic hypotension. There's another term, neurally mediated hypotension, that can actually be more commonly a delayed response. And this is thought to be a reflex drop in blood pressure where the blood pressure drops just a smidge more than in orthostatic hypotension, often preceded by symptoms that something's not going right, and then not associated with a normal reflex increase in heart rate. So any individual whose whose blood pressure drops should have a reflex response to increase their heart rate. That's normal. But in this neurally mediated hypotension, the heart rate does not increase. So 2 terms, neurally mediated hypotension, orthostatic hypotension. In this case, we thought, we didn't catch this, we didn't figure out why she feels so bad, let's send her for tilt table testing. And here's what we found. These traces here in red are her blood pressure. Top is the systolic, bottom is the diastolic. This is a really cool blood pressure cuff we have that measures blood pressure from beat to beat. So every time the heart beats, we get a blood pressure. It's a very constant measure. And you can see she goes from pretty stable lying down to when she gets tilted up on that tilt table, just like this little guy. Her blood pressure is no longer very stable. And in fact, it starts to drift. But if at any given minute, say 1 second minute, 3rd minute, 4th minute, 5th minute, we measured her blood pressure at a point where it's right here, we'd say, oh, you're fine. But see here, you see this drift as she goes down. She gets increasingly symptomatic while on the tilt table. Her heart rate has a normal reflexive response to this. It goes up. It says, man, my blood pressure, I need to keep it up by pumping my heart faster. And so it's responding. She gets tachycardia in response to this oscillating blood pressure, this drift down. But this tachycardia may, in some cases, be defined as excessive. It was an exuberant response to unstable blood pressure. So this is a classic example of orthostatic intolerance. What we can see in the laboratory, one of the things that was hard to measure in a normal office setting, orthostatic intolerance was not always used in the context of chronic fatigue syndrome, nor were autonomic symptoms recognized as part of the disorder. And it's really only been in more recent definitions of the disorder or the disease to include looking for autonomic dysfunction. Orthostatic intolerance, the prevalence is thought to probably be in about half, maybe more, and it depends on how you define it. So if you ask about symptoms, it's almost everybody. If you try to measure it physiologically, we think, oh, maybe half or less, a third. That means we may not be very good at measuring it routinely. So you can use symptom batteries to assess it. You can use the laboratory testing to assess it. So I mentioned the testing. We mentioned different types of protocols. The protocol I'm doing is a 10-minute tilt-table test. It's best at getting orthostatic tachycardia. If I wanted to find that neurally mediated hypotension, you would need a longer tilt table in maybe 50% of individuals. And that's where the cardiologists come in to help us with their more prolonged cardiac protocol of a tilt table. Otherwise, on those other parts of the battery, we have normal autonomic function. We don't see deficits that look like an autonomic neuropathy, for example, or autonomic failure. It's just the blood pressure and heart rate changes on the tilt table itself. And the cool thing is if you target treatment at these unstable blood pressures and exuberant heart rate, that you can actually make the overall symptom burden better in some individuals. Not universally, but in some. So how do you approach it? What are maybe some of the things you would do? So do's. So one is a review with an internist of medications that could potentially be contributing to the symptom burden, not just unstable blood pressures, but when gut and bladder aren't working, sometimes it's a side effect of medicine. Reviewing medications almost always can exacerbate some of the symptoms, and you decide the benefit of the medicine versus the potential it's exacerbating a symptom. Identifying anemia or even borderline low iron deficiency can be a very big thing for some individuals, and treating that may reverse a large component of the unstable part of the blood pressure and intolerance to being upright. Salt and fluids are probably the mainstay, and how much is enough is usually an individualized question, but a lot, like 3 or 4 times what everybody thinks they need, both in volume of fluids and in salt. And there's a cool little trick. Anybody who experiences orthostatic intolerance can use what I call the bolus trick. So if you take a glass or 2 of ice cold water and you glug it down, glug, 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 you get a reflex response of an increase or stabilization of blood pressure for up to 2 to 3 hours. Cool for going out to the grocery store, cool for going outdoors. It only works if it's enough volume and cold for some reason. It triggers part of those homeostatic systems we have. Because it's not a broken nervous system, it's just a sort of unstable nervous system in these cases, that bolus thing still works for many. Compression garments can be used as supplements to the fluid and salt, and really sometimes are the only way to go when you can't get in enough fluids or enough salt. It helps augment their effect. What to try to avoid? Dehydration goes hand in hand with getting enough fluids, and excessive exertion in hot environments. So anticipating that hot environment that's a stressful environment. Cooling vests have been used with some success by some, but anticipating and planning. Large meals cause all the blood to go to the stomach. Not as much blood stays out in the periphery where it goes up into your brain. So if you're upright for a long period of time after a large meal, you may be more susceptible to see these types of symptoms. Alcohol causes blood vessels to dilate. Again, not enough blood in the right places, increased vulnerability to the symptoms. And then lastly, and something not everybody thinks of, if you start a medication to stabilize blood pressure and heart rate, as I mentioned, treating these problems can sometimes help the symptoms. If you do it without a foundation of enough fluids, these medicines don't always work well. So sometimes the first try of a medicine is completely unsuccessful because there wasn't enough focus on the fluids to get the medicine to work right. So not just ladies faint. So the next couple of pictures I have are also gentlemen who have fainted. This young man stood in formation too long. And so I'll use him to talk about a young man. So he has had now a year of completely unexplained symptoms that came on acutely after a viral infection. his mom recalls he had essentially the stomach flu, but his stomach pain never went away and his fatigue never went away. It was like they described, he got mono, but he didn't have it. And he slowly declined in terms of his performance in school. The stomach pain was actually very debilitating, couldn't engage in his athletic activities. And then with time, he developed lightheadedness, some palpitations or chest, heart sensation, cognitive fog while trying to study, and had passed out twice. And all of this got worse with standing. So again, perfect example of orthostatic intolerance that he's describing here. Oops. So let's talk about syncope a bit. I like to use the pictures of the gentleman because women are overrepresented. Women faint at least twice as much as men in the general population. It's a very common experience. Most will faint in their lifetime once. And the range is anywhere from young, usually teenagers going on up, getting much more frequent after the age of 80. The causes for this, and I'm sorry, the print gets small, the most common is a benign cause and what we call reflex syncope. It can be triggered off by orthostatic intolerance. So syncope, reflex, benign syncope is more common in those with orthostatic intolerance. And the reason we all worry is because half as many as have the benign form could have a dangerous form. The cardiac forms are considered to be associated with increased mortality. And so that's why we work so closely with the cardiologist to look for dangerous forms. Orthostatic hypotension by itself can contribute a fair percentage, nearly as many as the cardiac or worrisome causes. And this, in any case, as I mentioned before, can be secondary to medications, dehydration, or eating a big meal in susceptible individuals. But also cardiac disease and factors that occur with aging that dampen down those reflexes of compensating for being upright can contribute to this. And then I have down here at the bottom, neurologic diseases are actually a relatively rare cause of syncope. So what happens normally when we stand up? So when you're lying down, most of your blood stays in your main chest cavity, a majority of it. When you stand up, a liter or so repositions itself to be in the legs, pelvis mostly. And that's normal unless it's excessive. In response to that, your body has some reflexes. It kicks up your muscle tone. It kicks up your sympathetic system to squeeze the blood vessels and get the blood pressure up. And that's all a normal compensation. This can either not happen enough and be low functioning, or it can be excessively functioning in some individuals. This is an example of a normal tilt table test. This is where they tilted up on the tilt table. This is where they tilted down on the tilt table. And you can see actually here there's some oscillations of blood pressure, but the blood pressure in red, and this is actually the heart rate in green, you see the blood pressure dips a little, the heart rate comes right up, and then it basically keeps the blood pressure pretty darn stable, very, very close in sync on a normal basis. So what about this young man that just passed out? So in the office, again, we try to look for causes. His heart rate and blood pressure, it's no heart rate. Let me tell you, it was 54. So he had low heart rate resting, and when he stood up after a few minutes in the office, not much of an increase. Oh, there's nothing wrong with you. Just go home. It's fine. We said, man, I haven't gotten the answer yet. Let's look for this. And what I'm looking for in this young man with stomach pain and this development of symptoms after a viral attack is a condition called POTS, or postural tachycardic syndrome. It's defined with an excessive increase of heart rate, defined by a couple different ways, accompanied by symptoms of the orthostatic intolerance, and typically is recorded after 10 minutes of being upright, and is specifically in the absence of a change in blood pressure. So none of those hypotension terms. So here's an example of his tilt table testing. Nice, stable blood pressure here in red and heart rate in green. And then as soon as he tilts up, his heart rate goes zoom. And he gets a change from in the 80s initially to well over 120, which he maintains the entire time he's on the tilt table. He feels lousy out here. And in times he'd said he would have passed out feeling that way. Pretty typical in terms of how he feels on a daily basis. So this is a pretty classic example of POTS, or postural tachycardic syndrome. Right now, the term or the diagnosis is mostly assigned to cases where there's not another suitable explanation, meaning you haven't found heart disease, you haven't found a neurologic condition, you haven't found a classic diagnosis of chronic fatigue, for example, to explain an orthostatic intolerance. This is orthostatic intolerance in the absence of any other explanation. It's often used as a comorbid term or diagnosed together, and that sometimes helps us clarify treatment plan. So there's no harm in that, but if you're speaking from the textbook, it's usually in the absence of another cause. The thought behind POTS is that there are probably multiple contributing problems in an individual with POTS. But a couple main ones we've been able to identify in the laboratory. So one is that of sympathetic neuropathy. It's a little counterintuitive. You said, well, the heart is racing. How is it that the adrenergic or the adrenaline sympathetic system isn't working well? Well, there's a limited neuropathy that's thought to be limited to actually lower extremities, leading to these blue discolorations and pooling in the feet of blood. And the neuropathy is sort of from the legs down or the pelvis down. And then in response to all this pooling, the system is saying, gosh, not enough blood is up here. And then in this case, there's an excessive surge of adrenergic or adrenaline response. So you have a combined underfunction and hyperfunction in this condition. And that's even too simple. Here's an explanation from the Mayo Clinic trying to sum everything up in one schematic, and I don't want you to try to read all of this, but the point is that in the middle, there's the venous pooling, and there's the increased adrenergic dysfunction. But there's a lot of else that's happening in these individuals. There's often pain that's occurring, and pain conditions are actually very frequently reported alongside of these symptoms. We think that they're related to similar pathology that's triggering off the nervous system to be super sensitive to the environmental stimuli. And then there's a sort of cycle that goes on where your response to the symptoms leads you to behaviorally do something like lie down. But then lying down a lot isn't necessarily a healthy adaptive behavior. That leads to worsening of the venous pooling, worsening of deconditioning, less fluid intake, and you actually then cycle back around. So the symptoms themselves lead to adaptive behaviors that don't help the symptoms, rather propagate the symptoms. So it's a very complex condition. Usually young individuals, anybody over 40, I look for another cause almost as a rule. Much more prominent in women than men. Definitely, I used a young man again as an example because we see it in men. Post-viral or post-surgical onset are probably the most common types of triggers that occur. Though sometimes they occur more slowly in onset without a clear trigger in some typical situations. And we've talked about the things that can worsen these symptoms, and that's not specific to POTS necessarily. The same list of do's and don'ts apply to this condition. So it's useful sometimes to think of things as orthostatic intolerance or just call everything POTS, whichever it takes to get these types of treatment plans in place. But there's also another mainstay to treating POTS that's different than that young lady with chronic fatigue syndrome where she had the payback fatigue. We think that these may be different pathologically because POTS gets better with exercise, whereas her condition was not. She was clearly worse after exercise. The trick here, though, is what we call a graduated exercise program. So individuals sometimes struggle to find this intuitively or find it without coaching, but it involves a routine where you begin with basically exercise from a lying position like a kickboard in a swimming pool, and you condition yourself to an aerobic capacity in only that position until the body has the stamina to exercise on a routine basis from that position, and then only then start exercising from a sitting position and then graduate to standing with time. It takes a while. Not everybody intuitively takes it that easy. Sometimes you do overdo it and get results you don't want. Also, strengthening the core and the lower extremities helps that muscle pump contribute, even if there is a neuropathy of the blood vessels leading to that pooling of blood, that you can actually pump with your muscles some of the blood back into the right places. And then this guy doing all these tricky looking maneuvers is doing some moves that help prevent passing out. So anybody who has near passing out on a regular basis can actually stop themselves in some cases. And these little lines, it's probably too small to read, but it's showing that he can actually increase his blood pressure by doing each of these maneuvers, preventing himself from passing out. So these are good little tricks: crossing legs, squatting down, crossing your legs again, or stepping up on a stool. Most maneuvers you can do publicly. This one looks a little funny. All right. So I looked and looked and looked for another male picture of a gentleman passing out, and I couldn't find an classic art illustration, except this very dignified looking gentleman who went crowd surfing, and now doesn't feel very nice. Lastly, let's see, talk about this last case here. So this is a 60-year-old who had been disabled from her employment as a physician, actually a critical care physician, and she had 6 years or so where she began having multiple domains of symptoms, symptoms affecting all these domains we've been talking about this evening, that came on really with no clear trigger. Most prominent was that she went from being a very avid bike rider to no longer able to do her usual bike routine, then no longer could play golf, then could no longer do really anything. Her headaches got worse, her sleep problems got worse, similar drill to what we've been discussing. She also, on her exam, when she saw me in the neurology office, had some signs of perhaps a neuropathy, some lost sensation in her feet that hadn't been previously appreciated, and some signs on exam of joint hypermobility. So I wanted to use her to talk about the longer list of things that can contribute to these problems. Approaching orthostatic intolerance is not just POTS and not just chronic fatigue with orthostatic intolerance, but it's a lot of things. And that's why I'm just a neurologist and I need help from a cardiologist and rheumatologist and endocrinologist because of all of these other things. So if I see a neuropathy, the list is pretty tight. I can check for these things. They include deficiencies of vitamins and metabolic diseases like diabetes. Some blood disorders as well. Fatigue is a common symptom we've been talking about. Common culprits: iron deficiency, I already mentioned, vitamin D deficiency, but I sometimes need the help of endocrinologists to rule out adrenal disorders, for example. Headaches, very frequent in this group. Sometimes it's just migraine or not just migraine. I'll talk about that more in a minute. Chiari malformation has been associated with autonomic dysfunction in some cases. Flushing, I sort of skipped past it, but this lady has heat intolerance, but she also says she gets flushing all of a sudden. It's very strange. She turns super pink. Flushing is a disorder that can be associated with autonomic dysfunction, or some of these, they're actually allergic type responses or chemicals in our blood causing flushing that are unrelated directly to the autonomic nervous system. And then GI motility, as I mentioned, can be prominent. Celiac disease, diabetes, common causes irritable bowel syndrome, as I mentioned, and then there's some autoimmune conditions. And lastly, we mentioned her joint hypermobility. And Ehlers-Danlos is just one description of a spectrum of diseases that cause joints to be extra mobile, and I'll talk about that in a bit more detail in a moment. So our case example had a little bit of all of these things. And sorting this out only takes, really can only go systematically through this list. So let's talk briefly about migraine headache. I would say that headache is almost a universal symptom, just as much as sleep dysfunction is among those with orthostatic intolerance, and it's a chicken or egg problem. We know that classic migraine, can have autonomic symptoms during the attack or leading into the attack. We know that if you go on to have chronic daily migraines all of the time, that the symptoms that come with an attack might stick around for a while. But we also know that orthostatic intolerance or autonomic dysfunction by itself can trigger off a headache. You can have a headache in response to that unstable blood pressure or unstable heart rate or too high blood pressure, for example. And so whether or not which is triggering which is sometimes difficult to tease out. What I do know is that directed treatment of headache very often impacts many of the symptoms, and luckily the treatment approach actually overlaps. So there's an emphasis on hydration in headache management, as well as some of the same medications we use for headache prevention work for the postural tachycardia. I mentioned joint hypermobility. Ehlers-Danlos is a genetic condition of our connective tissues, but most likely it's not just that far end of the spectrum genetically, but a benign joint hypermobility syndrome has also been described. If your joints are extra stretchy, that means your connective tissue holding your joints together are extra stretchy, and your blood vessels might be too. And so that's what we think is happening. We think the blood vessels are extra stretchy. So an individual with a genetic predisposition to having blood pooling because they have stretchy connective tissue might have a predisposition to, if they get a viral infection, for example, to develop POTS or to develop symptoms of orthostatic intolerance. There's also been the observation of a strong association between chronic fatigue syndrome and joint hypermobility. And there's an odds ratio of more than 3 times the risk in terms of observing both diagnoses. Lastly, that mast cell activation disorder is a very rare condition, actually, that can contribute to flushing. But I bring it up because it changes the way we think about treatment quite a bit. So it can cause or mimic many of the symptoms of POTS. The stomach pain, flushing can occur with autonomic dysfunction or color changes at least, and it can be associated with breathing problems or asthma. This is where the cells in our bodies that normally cause allergies on a sort of mild seasonal basis are overactive. And it can occur on a spectrum of either just a little overactive or even malignantly overactive, even leading to needing control with blood dysfunction medications to really tamp it down. In most cases, though, this can be measured by looking for histamines in the urine or the blood markers of this, and then treating it with a mast cell degranulation inhibitor. These are all the granules of the histamine, and they leave the cells when they get exposed to something you're allergic to. You can actually inhibit this process a little bit through targeted medicine. This can look exactly like POTS. And in fact, I could have shown you any one of those other little traces of the orthostatic intolerance individuals, and you wouldn't be able to tell the difference on the tilt table testing. So lastly, I mentioned this list of things, very thorough investigation. And this person who was high functioning, now had an unexplained disease, now disabled, had all of these things. We had to circle everything on the list. We went ahead and checked for everything. And she had normal markers of inflammation, normal metabolic and vitamin studies. She had a little bit of sign of some predisposition to autoimmune disease. She had an ANA, which is a marker sometimes associated with lupus. She had a slightly increased hemoglobin A1C, which is a marker for blood sugar, but not high enough to have diabetes and not high enough to explain her symptoms. But we found an abnormal antibody. And this is really the newest area in investigation of these conditions that I think is perhaps the most exciting. As we begin to discover these antibodies, we're going to find more and more that are treatable, autoimmune-mediated causes of autonomic dysfunction. So we got to cross out a few of those things with her blood tests and circle in something. I mentioned I still think she may have some things that predisposed her a little bit to getting the symptoms the way she got them. She had chronic migraine. She had the joint hypermobility. Maybe her symptoms wouldn't have manifested just exactly the same way in the setting of this antibody if she hadn't had those. But altogether, this is how it turned out. So we went ahead, we tried all of those things, the fluids, the stockings, the avoidance of large meals, the graded exercise, and she did a little bit better, but not a lot of it better. And so we went ahead and we targeted that antibody with immune therapies. And she experienced remission of her symptoms. In fact, is going back to vacationing actively with family. Now she can call her disability her retirement and is starting to return to life. But we anticipate to need to continue to support her because of that predisposition, her joint hypermobility. She's always going to be a little prone to getting a little dizzy. So we're going to support her with both approaches. So that's sort of all in a whirlwind. 3 examples of the scope of what we do there in our autonomic lab, the sort of how to figure it out and what to do about it. And I'd love it if I could take questions here or there's there is the opportunity to post this online, as I understand these slides, so they'll be available that way as well. So, yeah, go ahead.
I've always heard POTS described as postural orthostatic.
Yeah.
Is that the same as what you're describing?
It is. I'm a little pedantic. As you could see, I even made the little O little, because somebody decided at one point that it was repetitive to say postural orthostatic, because both of those words mean the same thing. So postural is standing up, orthostatic is supposed to mean also standing up. So they decided to do away with one of the words. Because POTS is so catchy, we kept the P. Yeah.
And just a follow-up question, your examples with heart rate going up, what would you say if I told you that my daughter has POTS and her heart rate goes from, 56 resting, just standing within a second,
Mm-hmm.
goes to like 156?
Yeah, yeah, I've seen that definitely, and that they sometimes the younger the individual, the more excessive or exuberant that heart rate increase can be. I sometimes tell my older patients with POTS, you can look forward to growing out of this a little bit, because the heart rate can't quite do that in individuals. So it's a predisposition. She's just so young that she's doing that. That exuberantly sounds like it'd be very consistent with POTS. Though, as you see, there's a lot of other things to investigate potentially before sort of writing it off as such. Yeah. Yeah. All right. Yeah. Yes. Mm-hmm. That's a great question. And many of these, she had actually been to the Mayo Clinic in Rochester and Arizona before coming to me. Had almost had the diagnosis once, but they sort of, they found it, but they didn't know they had, and they moved on with trying other things that didn't work. So number one sometimes is, to give it a relook every once in a while. And so when things aren't working, to do another sort of reevaluation. So oftentimes early on, we go through all of these things. We see everybody, right? 6 specialists later, there are no answers. You tried, exhausted a bunch of things. To sort of not necessarily close the book on things at that point. Maybe it was too early. Maybe the test hadn't been developed yet. This test here was just barely being developed when she went to Rochester the first time. They had it. They just didn't know they had it then because they didn't know what it meant yet. So a reevaluation periodically sometimes is part of the answer. And then patience through, sometimes we jump too quickly and we do too much at once. And so sometimes a deliberate stepwise approach through treatment or diagnostic approaches, that maybe things were done too much, you couldn't sort out what was what. At least that's how I approach, because a lot of people are in that position. Mm-hmm. Yeah. Mm. You're in great hands with Dr. Bateman. She knows when to pull the trigger on the reevaluation. There are definitely cases where there aren't other answers to find, and reopening the book isn't productive. And those tend to be hopefully the ones that they fit. We don't have the answer, but it fits a scenario. We sort of have our heads around what it is. We don't have a cause for many neurologic or systemic diseases in all of medicine. And so you're not alone in this category. But Dr. Bateman knows very well how to pull that. Oh, there's something out of line here. I want you to go and relook. So you're in sort of the best case scenario for trying to make that decision. Yeah. GI dysmotility sometimes is the hardest one. So not entirely. She still would identify probably as having irritable bowel, but more functional. She had intractable nausea that went away. It became more manageable. One caveat to all of this is if there is a true autonomic neuropathy of the gut, sometimes finding that other cause on this big long list, even if you say found lupus and treated lupus, if there was an autonomic neuropathy of the gut involved with that, it sometimes doesn't resolve. It's injury to the part of the nervous system that doesn't heal. Yeah. There is. So there are this. It's acetylcholine receptor. Our acetylcholine receptors are how our nervous system talks in every nerve we have in our entire nervous system. And there are a bunch of different types, and this ganglionic alpha 3 is one of those types. It's a type that's on the autonomic ganglia that is the transmission. I have a picture. It's sort of, let's see. The autonomic transmission, it comes out of the spinal cord, and the ganglia are where the nerves meet that leave the spinal cord and meet before they go off to their normal organs. I don't have the best picture, but so this ganglia right here, it's pictured here because of this antibody we found. It's thought to be it can either be blocked completely or lesioned by these antibodies, depending on how the antibody is affecting an individual. And because of the blocking, if you take the antibodies away, you might, then get recovery. There is an acetylcholine receptor antibody to muscle acetylcholine receptor, and there are specific subtypes that we have learned to look for, and there is a panel specifically for that. That condition actually is termed myasthenia gravis, and so it responds to some of the same medicines, but not exactly. So probably related in terms of at least sort of their like cousin antibodies. Yeah. Yes. Muscle control is both the muscles, a myoclonic term, and then muscle of the eyes can sometimes affect eyesight specifically. We don't think that antibody affects muscle function. It is possible that anybody who produces one abnormal antibody is probably at risk to produce any other abnormal antibody. So there may be one that's triggering muscle-related symptoms that we're not currently able to test for. There are panels. The panel that I use is through the Mayo Clinic in Rochester. They have a specific dysautonomia panel that includes this one. It also looks at the muscle-related antibodies. So there is this. Most doctors can order this. It's just a send out to that lab. So you don't have to necessarily see me to get it checked. Yes. Yeah.
But I know, like in the Mayo Pediatric Pain Clinic,
Yes.
they basically just say, punish your child if they show a pain response. And
Oh, goodness.
Push through. And so, how hard do you push your teenager with POTS?
Being a teenager is a problem in and of itself. It's hard enough to have POTS and to be a teenager. That's a little bit difficult because there are definitely, as I mentioned, the behavioral cycle and what they're trying to focus on, particularly with that age group, is this idea of trying to create, a different type of behavioral response to the symptoms, and they're trying to coach you through that approach. I usually talk about mind-body connection, and I talk to my teenagers, at least that are sort of cognitively able to understand this idea of that they're going to be the most fine-tuned mind-body teenager possible. That they have to think about how their body responds to how they think, how they feel, how they move, more than the average teenager. So they've got a job on their hands, and right now they're just laying around all day because they don't feel very well. So their job is to start to tune in. And so I teach them about mind-body connection as early as I think they can cognitively get their brain around it. And then we use that as an approach to learn about your body and how you can take it right to the edge before you're going to get that horrible payback. Right to the edge where you're going to gain some ground, but you're not going to fall off the cliff. And most teens, 13, 14 route and up, start to get a grasp of that pretty well with time. So maybe it's a little sort of the same thing because I want people to push themselves, but I want them to know where they rein it in. And that's only something that an individual can decide, and they take feedback from their system. So one of the most successful return to exercise therapies has been out of Texas, the Levine protocol. Have you heard of that? So what they do is they teach you how to figure out a heart rate that you get maximum symptoms at, and then you dial it back. What I'm trying to get at is something like that, but it's a little less fine-tuned.
So you're saying the band plan is successful because they use a mind-body connection?
I'm not,
You just have to deal with it and you don't try to ignore the pain, you just go through it.
I'm not sure how or why they're successful necessarily. I haven't been through their program, but I can recognize why that tool might be useful. Yeah. No. As I mentioned, and this is sort of, it's unclear territory still, but it's how I view things. That there's probably a continuum, but there's sort of classic POTS, and then there's this other end of the spectrum where there's clear, worsening or payback from exercise. And it's different than just pushing things and overdoing it. It's a true, inflammatory response that occurs in response to exercise. That, I think, is probably a different type of problem than POTS, which is why I'm so careful where I apply the term POTS, and why I called the case that we thought looked like chronic fatigue syndrome with orthostatic intolerance a separate entity potentially, because the pathology might be different. In fact, I think it probably is. Yeah.
Speaking of my teenage daughter, when she was little, she loved to swim. She could tolerate any kind of exercise whatsoever.
Mhm.
Very limited. She could be physically, but she could go out for short periods of time and swim.
Huh.
And Dr. Maitland thought that might not be helping her actually, because you kind of pump and all
Mhm.
that, helping her lower body and
Mhm.
maybe with the blood flow and something like that.
Yeah, I could definitely see that. It's also a sitting position. She's getting some. The difference, a POTS patient will tell me once they get on an exercise program, they'll say, if I skip a day, I get payback from skipping a day. And they know they need to go back to their exercise routine. That's the difference between this physical activity, the pumping, the sort of gradual increase of some conditioning is it's a different type of problem to have, and it responds differently than something where there's a true increase in impairment that's measurable on multiple domains after exercise. So, and I think we focus a lot in the laboratory to try to sort these things out for those reasons. Yeah. Great question. So a lot of big terminology here, but the punchline is there's a few ways. I mentioned extra activation of the sympathetic nervous system. There are blockers for that. So beta blockers, alpha blockers, those are blood pressure medicines that block that excessive activation of the sympathetic nervous system. Those are commonly first line in POTS. But there's also, if the idea of pooling of blood and extra distensibility in the blood vessel system is a problem, you want more squeeze. You can also extra squeeze it through activation of a different set of receptors on the blood vessels that make them squeeze and support blood pressure, prevent it from being unstable. That's called midodrine. Midodrine, propranolol, probably first-line medicines. There are a couple of new ones that work right on the heart itself. Don't let it pump as fast. And others that support the blood pressure through increasing volume and helping you keep the salt in that you do take in, and that's fludrocortisone. And there's some cousins to that work similarly as well. So 3 different ways we approach it. The ones that overlap with headaches treatment are these ones here, the ones that sort of dampen down the adrenergic responses. Yeah, I think it might be. Oh, yeah. 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 Mm-hmm, mm-hmm. It's like, part of me is like, well, just find another pool. Yeah. Yeah. Some people have the opposite problem and get overheated, and so the pool is helpful for trying to prevent getting overheated. You know, maybe a little much for starting out, but the next step in the most other recumbent activities are this recumbent bike thing and rowing machine. Those are you have to be very gentle with those to start out, but those are fairly recumbent and work well to pump the middle of the body, which is where you're trying to get the muscle pump to activate the most. And so through very gentle starting, I didn't put on my slide, but intervals are allowed. So I tell people they're allowed to rest in between. So you find that place you take right to the edge, not too far, and you rest twice as long as you just went. So you just went for 5 minutes, rest for 10, go another 5 minutes, build yourself up to getting 20 minutes a day through those little interval trainings are great. It's a way to build endurance without overdoing it. Yeah. Yeah.
But those of us that can't teach in class, though, I mean, not to split hairs,
No.
5 minutes when you are newly diagnosed or something is way too much. And so if you can set 30 seconds for yourself,
Okay.
honestly,
Yeah, yeah, yeah. Everybody, yeah, and that's what I said. It's such a customized place to start.
being on the floor in front of your fireplace. And that's where I had to start. Because I used to be able to run and lift weights and do all of these things.
Mm.
You know, people would say, well, we'll watch you in the car.
Yeah, 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 yeah.
Seriously? So, I mean, great exercise therapy is really great, but nobody specifically sits down and says to you, great exercise therapy is 20 seconds of you tolerating bicycle exercise
Mm.
to the end, and then resting for 5, 10, 15 minutes, and doing 3 sets of that.
Yeah.
So that you feel nice.
There's no perfect regimen. I mean, you can't. That's why these rehabs for the teenagers. That's why they're not universally working for people because you can't. There's no one size fits all.
But I mean, I think my goal now is to learn how to get into the pool. And so, I mean, and I used to go to the pool and it was great, but I really have to slow that.
Yeah, yeah, yeah. Uh-huh, uh-huh. I almost wonder. There are therapy pools that maybe, I don't know. Yeah, would be worth exploring. Yeah. 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 All right. Well, thank you everybody for your attention and questions. I'll catch you after. Yeah. Yeah.